So for this video, we're going to be discussing a general observational screen as well as a palpation assessment for the wrist and hand. Now to begin with, we want to look at the general posture or the position that the individual holds the wrist and hand in. That could be in a seated position. It could also be as they are walking. Is there a protective posture that they hold it in? Is there a general willingness to move and swing the arms during gait? Things of that nature. From there, we can also just observe the overall layout and makeup of the wrist and hand in a resting position. What I mean by that is, do we observe any redness, any swelling? Are we able to visualize individual bony prominences, tendons, vasculature? Can we visualize the ulnar styloid process and the radial styloid process? Things of that nature. All of those things let us know whether or not there may be signs and symptoms of inflammation, potential deformity, a change in the nature of the articulations where we might see ulnar drift, radial drift. We could see nodules within the individual joints due to RA or other rheumatic diseases. Additionally, we can look at the nails, and we can use this to visualize if there's presence of clubbing, which would suggest either cardiovascular or pulmonary compromise, as well as we can assess capillary refill, and whether or not there are any divots or indentations on the nails themselves. From here, we can take and bring the individual into a palm-up position. Several things that are visible here are the presence of wrist creases as well as the longitudinal arches. We can begin to see if there would be any atrophy through the thenar or hypothenar eminence, or if there would be swelling present visibly through the carpal tunnel. Additionally, in this image or visual assessment aspect, we can assess the individual metacarpal phalangeal joints, which are commonly locations where we find the presence of calluses. Those give us a bit of an indication as far as how the individual may use their hands from a functional standpoint, either in terms of physical labor or more activities of daily living. From here, we can begin our individual palpation assessment. Now, as we look at this, a couple things to be aware of anatomically that will help us in our assessment with our palpation. The joint structure is such that we have our distal interphalangeal joint and then our proximal interphalangeal joint. As we move more proximal, we find our metacarpal phalangeal joint. The metacarpals are going to come down and articulate with the carpal bones. We have a proximal row and a distal row, which we find just distal to our ulnar styloid process and a radial styloid process. This also would be where we find our carpal tunnel. Now, as we go about our palpation, we want to start in the carpal and then work our way out. So, the first carpal bone that's probably the easiest to identify is found at the base of the first CMC and just distal to the radial styloid process, and that would be our scaphoid. The scaphoid is fairly easily palpated due to the presence of the scaphoid tubercle. If we move just medial from there, we'll identify the lunate. The lunate is somewhat difficult to identify though, as it is going to be in an arch of which the median nerve and other neurovascular structures sit on top of. And so for this, our lunate is best palpated from the dorsal aspect and can be found at the base of our third metacarpal, just distal to, again, radial and ulnar styloid process. If you're having a hard time identifying the lunate and the capitate sit really one on top of the next, you can have the individual go into a bit of wrist flexion and the lunate should pop out into your thumb. A slight divot as you go into extension, and then it will come into your finger during palpation as you flex the wrist. From there, we can move lateral. Lateral is going to be where we find our triquetrum. We can identify that either from the dorsal aspect or the palmar aspect, and then sitting more or less on top of the triquetrum is the pisiform. The pisiform is just distal again to our ulnar styloid process, and you'll find that just proximal to the hook of the hamate, which would be in our more distal row. So, proximal row, scaphoid, lunate, trapezium, and pisiform. If we move to the distal row now, at the very base of the first CMC, articulating between the CMC and the scaphoid, is where we're going to find our trapezium. So we can come straight off of our metacarpal and drop onto the trapezium. Just medial to that is where we find the trapezoid, and the trapezoid is really going to be articulating at the base of the first CMC. So if we just, or excuse me, the base of the second carpal. So if we trace back, we can find that more on the dorsal aspect, and right there is going to be where we find our trapezoid. We noted the lunate sat just proximal. If we come back to our third metacarpal now and trace back, just at the base where we feel the joint space is where we're going to find the capitate. The capitate kind of serves as what we might call the keystone bone of that distal carpal arch. And so it's going to be right at the base of the third metacarpal. If we move lateral in this position, but really medial anatomically, we're going to find, moving from the capitate, our hamate. And the hamate is easily identifiable on this more medial aspect of the wrist and hand because we can identify the hook of the hamate. And that's also where we find Guyon's canal, which is a common entrapment site for the ulnar nerve. So we have a total of 8 carpal bones. With the palpation, always give yourself a bit of a reference frame. The easy way to do that is to kind of transition back and forth using the metacarpals as a guide if you're in the more distal row, and the radial and ulnar styloid process if you're in the more proximal row. Have a go with a peer or colleague, both with observation as well as palpation, and let me know if there's any questions.